Thank you very much for your very kind introduction. It's a great pleasure and honor to be here. I think I also would like to congratulate you to the set up the unit for research on health economic aspects of cancer. I think that's a very timely unit to set up. And it reminds me about Sir Peter Medawar. He wrote a book about advice to a young scientist, and Sir Peter Medawar got a Nobel Prize in Physiology, I think, in 1964. And of course, he talked. It's very important to be equipped. You should know all the different methods of statistic analysis and so on. But the most important is to have an important question to do research on. And I think that in cancer and health economics of cancer, we have really an enormous amount of questions, and I'm afraid that I'm going to add to those questions. I'm maybe not providing so many answers. I'd like to thank for the title of my speech as well. It was Personalized Medicine in Cancer Treatment in Europe. I think it's a great title. I think I can talk about anything with that title, so I'd like to thank Brendan very much for that title as well. But of course, I am a health economist, and you know that health economist is talking about allocation of resources. We have talked about cost, but it's not only about cost. It is about choices. It is about choices of watchful waiting and prostatectomy and a lot of others. And it is about positive and normative economics, giving advice how things should be, but also trying to understand how things are working. I also have a little of another hat in this. I am leading a task force for evidence-based cancer medicine and cost-effectiveness within the European Academy of Cancer Sciences, which is basically under the auspices of ECHO. And I think ECHO is 66,000 oncologists. And I'm the only economist. I feel very humble in this situation. But of course, also I think it's great that I've been charged with sharing this task force, because I think also it tells a little that probably the health economic aspects are important. And we have a vision for the task force, as you can see here, that we would like the decisions about access and use of cancer therapies by patients, payers, and providers. You see a lot of new stakeholders here, based on the relevant evidence on effectiveness and cost effectiveness. So it's only one little word of what's relevant. And we have seen how difficult. But the key issue here is, of course, about evidence. And I just showed you the members of the task force here. It's a combination of Frans Rutten, my colleague from Netherlands, the health economist. We have two very, very senior oncologists on this task force, and you know Ken Patterson, who was the chair of the SMC in Scotland. So it's a rather interesting group. We are going to make a presentation in October at the ECHO meeting, and I just like to share with you a little about our thinking, because I think this is very important in these times we are now, is to really get the issues. What are really the important issues, and trying to focus on those. I will talk about personalized medicine also, but personalized medicine in a way is basically a way of trying to identify value for patients of treatments, trying to treat patients who will respond to treatment and not treat patients who will not respond to treatment, and try to make that, and of course also try to select if they have side effects. So it's really about selecting a patient between watchful waiting, surgery, radiotherapy, drug therapy, so it's really the key. But I think also we have to be a little careful in a way to not oversell personalized medicine, because we have always diagnosed patients and tried to find out which patients who would have most value of a certain therapy, as we do here. But it is about development and evidence, and it's about development of evidence in clinical practice, as we have seen here. It's development of evidence for health technology assessment and decisions about reimbursement, because the stakeholders are not anymore just the doctor and the patient. The stakeholders are also much wider here. I think we have to take into account the type of information they want. But of course, it is, of course, patient access to new treatment. And we have heard about here with the new expensive treatments in cancer, patients go bankrupt unless the government pays for them. So that's very important. So it's about pricing and affordability as well. These are traditional economic issues. So you can say that the whole issue of what you call translational medicine has obviously been extended. This is just to show a little of a slide I did together with Niels Wilking, who is an oncologist I've done a lot of work with. And this is just some very brief data here about how we use new cancer drugs in Europe. And you know, in the 1950s we maybe had 1 or 2 cancer drugs, and today we have 100 plus cancer drugs. And you can see here just between the European countries is an huge variation in the use of these drugs. So there's probably overuse and there is underuse, and we don't really know. So we have the same question here: what is the appropriate use? And of course, if we are looking at it also over time, it looks like mountains are going up here. This is a new cancer drugs in some different countries, and you can see that in Europe, France is using new cancer drugs at about the same speed as the United States, while you can see, for example, United Kingdom is having a more cautious view on taking in new. And it has, of course, to do with evidence, but it has to do with a lot of other things as well. So you can, of course, see with this enormous speed of change, you're not surprised that there are variations between countries. And we could, of course, look at even individual drugs. This is trastuzumab, this is a Herceptin, it's a drug introduced for breast cancer, targeted drug. It's personalized medicine, really the first big case. And this is a personalized medicine drug. It's for HER2 positive breast cancer patients. And you can see here where the green line is Russia. We can have a discussion if they are in Europe or not. But you can see also that Hungary and Poland is using very little. France is using quite a lot, and Sweden obviously is using much less than France, and France was more. So even with what we call personalized medicine targeted drugs, a huge variations in the use. So it's not automatically solved just because we have a molecular target. And you can see because the reason for these are quite obviously. If we look at spending on cancer in Europe, first thing observation is of course, well, we don't really know what we are spending on cancer. We only think to know that we are spending too much. But if we are still looking at the data which are there, we have a difference with a factor 15 with the highest and lowest spending, 344 euro or 22 euro, where I think is Romania, and 342 I think is France. So you can see with this huge variation, obviously it's very difficult for Romania, even being part of Europe, to buy these new drugs. And of course, we have to, of course, since we are talking about Europe and we are talking about the European policy, we have to think about this as well. So that we are acting here. So should we develop new targeted medicine? But huge populations in Europe will never be able to use them. That's an important economic factor. It has, of course, to do with reimbursement. That's one key. We're very focused on NICE, who has evaluated 148 cancer therapies. And I think they have said yes to about 60%. And they have said no to about 30-40%, depends a little how I think. That's very important decisions, and I know that Ireland has a similar system. So it's about how we make our reimbursement systems, and they are not done by patients and clinicians. They are done by special experts groups who are using economic modeling. We have, of course, also variations in practice patterns, which, of course, is due to different interpretation of the of the medical evidence. And I just taken Sweden as an example. We say, well, Sweden differs from other countries. Well, I don't have to go outside Sweden. I can look at 6 Swedish regions. This is a targeted therapy for Herceptin. It's nearly a 50% difference between the ones who are using most and the ones who are using less. And what is rather interesting is that we have no clue if they are using too much in the one or too little, because we have no data. We can't link individual testing data and treatment data. And ecological data, we can make statistical analysis of these. Actually, the one who used most has the highest mortality in breast cancer, but it doesn't tell us anything. So it's the problem here, of course, about data. This is another drug, Avastin bevacizumab. It has been on the market since 2005. Huge variations. We have no really clue how we are still after 8 years exactly should use this drug. We have 2 new drugs. And the new drugs is rather interesting because they are priced in the magnitude of 100,000 euro per year. So that's about the salary of an oncologist in Sweden. Okay? So since we have a budget for drugs and all other services, we treat 1 more patient, we have one oncologist less. So there's a trade-off, it's an opportunity cost on this here. And we have rather limited, and it's not only one, we have one targeted therapy, which is vemurafenib, and we have one non-targeted therapy, ipilimumab, in malignant melanoma. And of course, we can return to prostate cancer. Prostate cancer is very, very interesting because, as you say, apart from surgery, not really so much has happened for a very long time. Now we get a number of new drugs. Cabazitaxel is a variant of some old drugs, but abiraterone is a totally new drug which works in a totally different thing. It has one big advantage, it has much fewer side effects. And men in my age take a lot of notice on that, I think. So that's very important. But of course it carries an enormous cost because docetaxel, which it replaced, is generic. It cost 5% of it cost 2 years ago. So that's a type of the trade-off we are getting into. If we are looking at spending, as I say, we don't know exactly how much we are spending on cancer, but Nils Wilke and I, we have been looking at the sales of cancer drugs in Sweden. And this is rather interesting because this is totally, I think, contrary to what we think. If you're looking at here, we have dramatic increases in sales of new technology until about 2008. And after that, it's more or less flat and even going down. So actually, it is not exploded, at least not from a cost point of view. The problem is not the cost. The problem is that we don't know how we should use the new technology about their value for money. And if I look at the top 20 list, we have 100 plus cancer drugs on the Swedish market. From a cost perspective, you can see that about 60 is a rather good drugs because those 60 account for 5% of the cost. These 20 drugs of the 100 account for 75% of the cost. And there's a few drugs, of course, who are cost very much. This is trastuzumab, rituximab, imatinib. It's rather old cancer drugs now. Actually, the only one who of the newer drugs is lenalidomide, which I think came some years ago, which has sold for myeloma, which has sold. So actually, that's rather interesting also. Most new technologies, at least if we are looking at pharmaceuticals, are used very little and have very small cost. But of course, there is a few one who is really, and it is interesting to see at the top of the list, we have 2 targeted therapies. We have imatinib and we also have trastuzumab in this case here. But we have to, of course, understand very carefully how are we making our decisions about these new technologies and what are the policy implications here. Well, one very important issue is, of course, how can we make new cancer treatments more affordable for the European population? It seemed to be not very good economics to develop new drugs When you have developed them, you have put all the costs in. Then when you have them, they're basically, as an economist, it's a sunk cost. Using them is zero. Then we price them on €100,000 and we don't use them. Okay? Is that sensible or not? Or how could we actually go towards more? And this is interesting also in this market now. We are going more to price discrimination. But we may also think a little about, in a European perspective also, how we use new cancer drugs and evaluate them, because if we are not using them, we can't evaluate them. So we have to think a little about what we are dealing with here. And how could we improve our health ability of the healthcare system to make more rational choices about resource allocation in cancer, which are more aligned with clinical evidence and cost effectiveness, because we can see now that we are really having two big differences for they are being rational. And of course also, how can we improve evidence on outcome of new treatment? Because cancer is a serious disease. We would like to have new treatment, and when we have some new treatment, through personal medicine technology, etc., we obviously would like to use this as soon as possible. Nobody likes to sit and wait and having, because time really matters in this case here. So we would like to have them as quick as possible into the market. But the quicker we get them, the less information we have. So we like to be well informed and having rational decisions. So we're really sitting between here, because as economists make this distinction between experience goods and search goods. And experience good is, well, you try it out and then you see if you like it or not. So, it doesn't work with new cancer medicine. These are our search goods. We have to try to provide information, and we have to try to find out information how we should use them. So then it is about value, and it is about evidence, and it is about stakeholders, but also type of evidence. So we have to know the effect of outcome. That is the key. Then, of course, we can start about how much it costs to achieve that outcome, what the value is of the goal. But if we don't have data on outcome in clinical practice, we are lost. We have nothing. So that is really data on impact of survival, quality of life, and other in clinical practice. And we have had a discussion, a wonderful discussion here, about clinical trial information, which has a high rate of internal validity. And of course, we have the observational studies, which also a high rate of external validity. And we have to say, we have to be able to combine these even, because it's not either or. It's both, and we have to use them both at different times. So we also have to, as you say, we have to do more randomization in clinical practice and things like that. So it's about evidence of outcome, but then it's about value of outcome, because outcome is having an increase in survival. That's fine. Increase in quality of life. Well, who's going to value this? Look in prostate cancer now. There is really not so much evidence that the new drugs improve survival. But there is a very good evidence that they improve quality of life. So how do we do the trade-off between survival when we are doing the evaluation? And we have to have the data for this. We have to discuss about the cost-effectiveness estimates, etc. And then, of course, that's all. We can do that. We can estimate cost-effectiveness, and I think health economists can contribute widely here. But, of course, we also have to be modest and saying that the cost-effectiveness ratio, it's a tool, it's not a rule. I think Michael Rawlings used to say that for nice, and I think he's right. There's still someone has to make a decision. And how we organize our decision-making structure here. In Sweden, we are debating very heavily, should the central government make this decision? Because this is about all Swedish patients should be treated equal. It's about innovation and research and so on and so on. But we have a regionalized healthcare system where the regions make all the decisions about all other cancer drugs, or all other cancer resources, and they have responsibilities for all cancer patients. So should the government be responsible for the new cancer treatments, until they fall out, and then they transfer over. Well, this is the debate we are having at the moment, and of course the government is thinking very well, how could you help us to make these decisions? And then of course you can study, as health economists also, how are they actually doing those decisions? Reveal preferences, because they can avoid everything but not doing the decisions. So just a little about the new evidence landscape, because we are used to that the clinical trial is really the gold standard. You make a clinical trial and you decide about market authorization, and that's it. So market authorization is they're allowed to sell the drug on the market. It is, of course, an indicator of evidence of value, but it's rather limited. We have a lot of other techniques: evidence-based medicine, comparative effectiveness research, health technology assessment, etc. And what we are seeing here is, of course, that the evidence process or the evidence landscape is changing here. In this paper that I did together with some colleagues in US and Europe, we just try to sort it out after two different, angles. The first is about evidence generation, evidence synthesis, and decision making. And the other is about the question: does it work? How does it work in clinical practice? And what is the value? And what we are seeing here now is, of course, that the whole evidence landscape with different decision makers are changing, and we have to take into account that evidence has to be produced within this type of landscape. So what can we do to be a little practical? What can we do before market authorization? Because could we change the clinical trial? And just to return to personalized medicine. Personalized medicine, of course, has a change to change the way we are doing clinical trial. But what are the key issues when it comes to clinical trial? Well, it's still about, are we applying the right population, the same as we do in clinical? We discussed age in prostate cancer. Is the intervention applied in the same way in clinical practice as in clinical trials? I have seen some shocking data, and that is about, if we're looking in cancer, that the number of, say, cycles in chemotherapy giving in clinical practice is maybe half of what is given in clinical trials. Is that true? Do we know that? What are the consequences? Well, for the new drug, it's a good thing because it makes them cheaper if you use less of them. But on the other hand, is it totally meaningless to use half of the dose? So we have to think a little about that as well. We have to look at the comparator. And we also know that in clinical trial, it's an experimental situation. You can make one comparator, and then you can very difficult to have a lot of them, and it's very difficult to have active comparators and so on. So, but you can do some. And then, of course, it has outcome. In cancer, we look at progression-free survival because that is, you can measure it, and you don't have to worry what happens afterwards. But of course, what happens afterwards is really important, both for cost and for survival. So we can do a lot, and there's a lot of work going on today in, say, early advice to pharmaceutical industry and other developers of drug, how to change the market authorization clinical trials. But basically, you need to do a lot after. And the change to personalized medicine is, of course, that we can probably do smaller, more focused trial, but the consequences of that will also be, we'll have more information. We need to do more when they come into clinical practice. I think prostate cancer now, 3-4 drugs coming in at the same time, and we will use them in combination and sequence, but they are evaluated everyone by itself. So clinical trial, personalized medicine is helping us enormously to define patients, etc. But we will have at least the same problems as we had before in order to look at at outcome, what is now called comparative effectiveness. And it's rather interesting now, if you are watching the EMA, the European Medicines Agencies now, they are focusing more and more on adaptive clinical trial in order to assess more of the value downstream of new drugs. And they are focusing on risk-benefit analysis more, and they are focusing on post-authorization efficacy studies, which will be part of the regulatory process. So interesting to say, regulators and HTA agencies are basically moving in the same direction here. As you can see here, everything is focused on, we see here, it's what happened in the market. The assessment of value, which is the key in this here, must be seen from what is happening in the market. So if this is going to happen in the real practice, well, what data should be collected? In a way you can say, well, we use the data we have, and we do instrumental variable techniques with whatever we have. We do cost data with whatever data we have. But I think that we more and more really have to think about what data are we needed, and we don't have those data in our administrative databases. There is a need for, I think, what was said, prospective trials in clinical practice. So there is a number of things, of course, which could be improved on this, and I will particularly only, since I'm going to talk a little in the European perspective here, with personalized medicine we will precisely define, say, 4% of patients with lung cancer which respond to a new drug. That's a rather small percentage of the lung cancer patient. And then, of course, if we like to have quick information about consequences, etc., we would like to share databases, or we need to share databases between countries.